Yeah, dear Chairman, ladies and gentlemen, during the course of the day, we have heard in different presentations already the problem about the myocardial restructuring during LV unloading, and I would like to give you some more data and details and point out to the possibilities which might exist in order to increase the usage of LVADs as a bridge to recovery. So today, the LVADs are used mostly 90%, 80%, as a bridge to transplant, bridge to bridge sometimes, but now increasingly as destination therapy for older patients, patients with tumors whatsoever, and as a bridge to recovery. And recovery means in most instances the diagnosis of myocarditis is still very limited. And I think in most centers it's limited to around 5% of all the patients who are supported with a mechanical assist device. It is known already for a long time that prolonged and near complete unloading, I think this is important, and there seems to be differences between those devices who are providing a complete unloading and those who are providing only limited unloading. Complete unloading of the left ventricle may be, and it may be associated with a structural reverse remodeling that can be accompanied by functional improvement. Remodeling means the bad thing, that the heart is dilated, is undergoing changes, and what we are always trying to do is to either reverse remodeling or to restructuring the left ventricle. The percentages in the literature are something between 5 and 24%. And there is also a high early recurrence after removal of the assist device in patients that they deteriorate again, and you have to do something either to reinsert a VAD or HU transplant or whatsoever. And there is only one study which is completely different from all these other data, and this is the study from Mrs. Birks and Jakub in 2006 in New England Journal of Medicine, where they have provided advice how to increase the percentage of patients supported for recovery, and this not only for myocarditis, where we already know it that it will be possible, but this is for patients with non-ischemic cardiomyopathy. And what they have done is that they have used drugs known to reverse left ventricular remodeling. The cardiologists have a very wide spectrum of active and potent medications, and these are all given. And there's also given glenbuterol after regression of left ventricular enlargement, and this glenbuterol is a beta-adrenergic receptor agonist to prevent myocardial atrophy, and I want to come to this point later again. Now, they have included 27 patients in their study. 3 had ischemic cardiomyopathy, so we are left with 24. Of these 24, 4 were in cardiogenic shock, and 20 patients were finally investigated, of whom 5 did not complete the course of pharmacologic therapy. And I think one of the problems with this scheme is that you have to use very high dosage of beta blockers and so on, and then the blood pressure goes down so that many patients just don't tolerate this kind of treatment. And obviously this occurred in this study as well, and 4 of these 5 patients died who could not undergo this pharmacological therapy. So we are eventually talking about these 15 patients. Of these 15 patients, in 11 patients, the LVAD could be explanted, 4 had to be transplanted, and in the long-term follow-up of these 11 patients, 1 developed carcinoma of the lung, 1 had intractable ventricular fibrillations, and 9 actually were long-term survivors. And of these survivors, 100% were alive at 1 year and 88% at 4 years. The quality of life in these patients were nearly normal, and 59 months after explantation, all these hemodynamic data were actually excellent if you consider that they were all in Myocardial 4 at the time of implant of the LVAD. So actually, the bridge to recovery in non-ischemic cardiomyopathy patients were almost 50%, which is extremely good, and there is, I think, no other study which could show such a high incidence of successful explantation of LVADs in a non-ischemic dilated cardiomyopathy. That means no patients with myocarditis were included. And therefore, the conclusion is that a reversal of left ventricular remodeling is possible in selected patients even without acute myocarditis. Now, the question is, how does that work, or what can we do in order to improve the percentage of patients with bridge to recovery? First of all, the cells undergo, the myocytes undergo characteristic changes. For example, here during idiopathic dilated cardiomyopathy, cells are getting bigger, hypertrophied, and after LVAD implantation, they are almost back to normal. These are normal cells, cardiomyopathy cells, and these are cells after LVAD implantation with complete unloading of the left ventricle. So this is actually exactly the effect what we want to see. But they not only look okay, but they are also functionally okay. And this is done already in a study in 1998, so it's a over 10 years old study where you could see that even the function of isolated cells after LVAD support were in the normal range. Also, the response to adrenergic stimulation was or became more or less normal, and all this shows that the myocytes after LVAD implantation had the ability to regain viability and contractility, and this is also shown here in this slide now again, where you could see that the cells with the volume, length, width of the cells, thickness, and so on, in heart failure, and then with the LVAD supported, were almost as good as those in the non-failing group. So this would just show us that the LVAD is doing the right thing, namely that there is a recovery of the heart. Not only the heart is going to be recovered, but also the blood pressure and flow within the heart is recovered under LVAD support. That means the subendocardial flow is improved, which might be one of the reasons why all these cellular changes do occur. Here again, another study from 2005 also showing that LVAD does a normalization in cell volume, length, and diameter. However, and now we are coming to the next point, that as soon as the LVAD is in place for a longer time, these cells undergo further changes, namely back from the normal appearance now to atrophy. That means that they obviously get the message that they are not necessary anymore because they don't have to do anything, and therefore they undergo cell atrophy, and this is the phase where also LVAD explantation seems to be almost impossible because the cells have atrophied and there is no way that your own heart cells will have enough power to regain the necessary contractility. In addition to the myocytes, the next question is, what's about the fibrocytes and the interstitial fibrosis? And we've talked about this shortly this morning, that we know that the sarcomere itself have only a very limited capacity to contract. However, as we all know, we have an ejection fraction of 50%. And this ejection fraction of 50%, even though the sarcomeres only contract to 15%, is only possible by having the structure of the heart which we have. Once it's dilated and all the muscle fibers are not in a spiral way anymore, but they are round in a dilated way, then even if you have a heart with normal muscle cells, contractility is going to be reduced down to 30 or 25%. And in the cardiac surgery operating room, we will see this all the time when we have a patient with a very bad ejection fraction, when we put a vent in the heart, thereby reducing the size, and then look with echo to the contractility of that heart, it looks great. And that's, the mistake of many beginners. Once we are going off bypass, we think it's fine. I mean, we have done great things. The heart is contracting well, no problem coming off bypass. But as soon as the volume is going back to the heart, the fibers again stretch, they're coming circular, and all the good contractility in the beginning is gone. And the same might occur also after LVAD explantation, that as long as the heart chamber is being reduced, contractility might be okay, but then once the old shape of the heart is being restored again, the same decrease in contractility occurs. Therefore, there is so much interest in the question, what happens with the interstitial fibrosis during LVAD insertion? Because that's the second part, which is so important, not only myocyte recovery, but also fibrosis. What does occur with fibrosis? Now, unfortunately, even though with the myocytes, the data are relatively uniform, and they all show hypertrophy, normalization, atrophy in a time-wise fashion, with the fibrosis, it's not clear at all. There are several papers showing reduction in fibrosis, others show increase in fibrosis, and other studies again showing no change at all. So actually nobody really knows what in a specific patient might occur with interstitial fibrosis. And this is not new. So here is one from the Cleveland Clinic in 1995. They could show clearly that the left ventricular dimensions are being decreased with the LVAD implantations, but they also showed that the fibrosis before LVAD and at the time of explantation, so these were all patients in whom the LVAD was explanted, had even increased from 1.3 to 1.9. So this is a field where at least I could not find any firm data what happens with the fibrosis. Now, looking to the morphological and molecular changes following insertion of LVAD, there has been already also many studies done showing that there are tremendous molecular changes pre and post LVAD, so that clearly the changes in the myocytes are related to these molecular changes. Now, we ourselves have a mechanical assist program where we are implanting now around 30 assist devices, including total artificial hearts and all different sorts of LVADs. And our experience with a transplant after assist device is rather good, and that means that the results of those patients after transplantation without LVAD are even worse than those who had an LVAD, even though that the surgical technique itself is, of course, extremely difficult once you have an LVAD in place and then do a transplantation. But the reason is that these patients are in a much better condition when they are being transplanted than those who are mostly in Germany, unfortunately, on the high urgency list, and they are in a really relatively bad conditions. Of course, in this graph is not included the death rate of the patients before transplant. That means between LVAD implantation and the time of transplant, there is also a mortality, and this is not included. So this is only the data after transplantation and not before transplantation. We now have a research project about VADs, which is supported by the German Research Society for the next 2 years, and I'm going to show you some of our first work in this project. This is done together with the Department of Pharmacology, and Dr. Rulski is one of my co-workers whose data I'm now going to show. What we try to resample in mice is that the pharmacology departments have a huge knowledge about gene expression, this and that, all in the mouse. Therefore, we try to do it in all these experiments in mice and not in rats. And what we are trying to do is to see what kind of changes do occur with reverse cardiac remodeling. Since this is, of course, in the mice not possible with an LVAD, they choose to have a reversible transverse aortic constriction in the aortic arch. And therefore, they have reduced the transverse arch diameter from 1 millimeter to 0.3 millimeter, meaning a 70% decrease the afterload increases if you don't do anything up to 12 weeks. And if you release the ligature, there is cardiac unloading, however, not coming back to the sham-operated group, as shown here, even not after 12 weeks. Here are some data showing the echocardiographic proof that there is a severe aortic stenosis. These are the histological slides of these animals, and even after relief of the stenosis, there is still some stenosis left, which diminishes then after a longer period of time and not immediately. Here you see the aortic arch internal diameter, which is being produced and then eventually is being reversed. Left ventricular hypertrophy is being produced, and the heart to tibia ratio is shown here. Cardiomyocytes, as you see, go up and then go down again, and also the NPPA expression is shown on the right side. The same occurs with left ventricular function. Ejection fraction is shown here, which is going down and going up again, and fractional shortening showing the same pattern. In our studies, at least, in this model, the left ventricular perivascular and interstitial fibrosis is also being increased, but then after release, it's not going, at least after 12 weeks, it's not going back to normal, but it stays significantly increased as compared to the sham-operated animals. Therefore, myocardial unloading, at least in this model, leads to partial normalization of cardiac hypertrophy and LV dysfunction, and is associated with persistent fibrosis and sympathetic activation. Taking all these together, I think that the LVAD, if one is going to use the LVAD as bridge to recovery, and if we want to increase this usage of this kind of medical device for bridge of recovery, we have to remove it before cell atrophy occurs. Therefore, we have only a narrow window of device explantation. In this view, the one case report, what we also spoke about this morning from the Jakub group with this 10-year-old or 10 years after implantation of the heterotopic heart transplantation is very interesting because it contradicts everything I've just said. But I think this should be also looked further into. But definitely after cell atrophy, which occurs only after complete unloading, any explantation is too late. Therefore, all these data might lead to the development of new assist devices, meaning that we do have now cyclic devices which allow a restructuring of heart chamber geometry and even might allow training of these cells again. And this is now done for different reasons with a new version of the Jarvik 2000, that they, every minute, they are reducing the flow, the revolutions per minute in order to allow ejection of the heart. They don't do it for the reasons I just said. They do it in order to wash out any potential coagulation which are in the left ventricle. But this might be also a necessity for the future, that we are still training the myocytes in order to have a heart available which can support the circulation even after explantation of VADs. Then the normal, quote-unquote normal, heart failure therapy, of course, has to be implanted. And still unknown is the fact what glenbuterol does. There have been many controversial discussions about the positive or even negative effects of glenbuterol. Nevertheless, I'm not aware of a study who could resample those very good results of the London group, because 50% in a non-ischemic cardiomyopathy would be fantastic if this could be achieved. But I think we all have to work further on the subject, and this basic science day to day is maybe another step in this direction. Thank you very much.